All right, JJ, shall we get started?
I think so. I think so.
Awesome. Well, really big special thanks to Ryan Jackson, who set up this session. I'll hand it off to him shortly. But we have an all-star lineup today on multidisciplinary approaches to oropharynx cancer. We have Zoe Fullerton, who's the fellow presenting under Ryan Jackson from WashU. We've got Dante Merlinos, the fellow presenting under Karthik from UPenn. We have Zachary Huntinger presenting under Linda Yin's supervision and mentorship from Mayo Clinic Rochester. And we have two excellent discussants today. We've got Wade Thorstad, who's a radiation oncologist. It's always great to have that particular opinion when we talk about oropharynx cancer and its implications from WashU. And we've got Baran Summer from UT Southwestern, who is not a radiation oncologist, but a fantastic surgeon and leader in our field. So I'll hand it off to Ryan and looking forward to this great session. Thanks, Ryan.
No, thank you, Tony. Really appreciate it, and glad we could get this panel together somewhat last minute. But I think we have a pretty excellent lineup for tonight. So the format's the same. I don't know if the fellows have been on one of these before. I assume this is their second one, correct? So hopefully they know the format. We'll do a 20-minute presentation for each case. We'll have our experts weigh in on their expertise and experience on some of the finer points to help the fellows out in the audience. Tony, will somebody be monitoring the chat? Because I'm pretty terrible
Yep.
about staying on track.
Yeah, that'll be me.
Perfect. So just holler at me and interrupt if a message comes up, and we'll do our best to answer people in the chat. Why don't we start with Zoe Fullerton first, just because I know her. She's been with me for the past 3 months, and this is one of our cases, and we'll kick off the night.
Great, sounds good. Um, so we'll be presenting a case on a base of tongue tumor today. So this was a 60-year-old male who presented to clinic with a left neck mass, a sore throat, and that was persistent despite multiple trials of antibiotics by his PCP and mild dysphagia, which had developed over the past week. He was a former smoker and had had a tonsillectomy as a kid, but otherwise it was fairly healthy, had no significant comorbidities. On physical exam, he was notable to have this left neck mass that was firm but mobile from the surrounding tissue. We were able to palpate a lesion at the left base of tongue, which he didn't appreciate, and the tonsils were surgically absent. We scoped him, and these are some images from his laryngoscopy. You can see there's a left base of tongue mass that was visible. It involved the base of tongue without involving the lingual surface of the epiglottis, and there was minimal extension into the GT sulcus or the tonsillar fossa. But there was it did go pretty far towards the midline. These are some select images from the CT scan that we got for him. You can see that there is a kind of left leaning but extending towards midline base of tongue mass that extends a little bit deep into the base of tongue musculature without clear extension into the intrinsic musculature. He also has a notable left neck node.
Let's take a pause here, and I want to ask Dr. Sumer some questions from a surgical standpoint. You see these scans, you see that endoscopy. What exam are you doing on this patient as well? Is there anything special you do for tongue-based cancers as far as examination in the office before you would even take them to the operating room? JJ, do you know if Baran's on?
I thought I saw him. Hang on a second. He was and then he wasn't. Let me see if I can track him down. Yeah, he's
While you're
not.
doing that, maybe
He
I'll
may
answer my own question then.
have.
So yeah, basically a good examination you want to do on these patients is not just feel around the back of the tongue. You certainly want to do that. And I always recommend doing that before you scope the patient, because you might see some bleeding, you might see some irritation around the edges, or if it's an unknown primary patient, you don't know where the primary is, it may help shed some light on where the primary is. But on these tongue-based tumors, you also want to feel under the tongue along the floor of the mouth posteriorly. And that gives you a better sense of how anteriorly this extends toward the extrinsic tongue muscles coming off the hyoid bone. If you can feel a lot of tumor underneath their tongue in the floor mouth, that's much more concerning to me when planning surgery, whether or not I would even do it. Zoe, what did you guys think about these images as far as resectability? What did you see was favorable or unfavorable about this patient?
In this case, we did not think that there was maybe a little bit of extension into the extrinsic, but certainly no extension into the intrinsic muscles of the tongue. So we felt like we could get around it. The tumor does kind of extend deeply towards the hyoid, but it does look like there's a plane between it and the hyoid, which I think made us feel like we could get a negative margin, if it was a close margin.
Okay,
We
great.
talked a little bit.
Yeah, I think that's important. I think the surface area of the tongue somewhat important. This is probably on the bigger side as far as width and how much volume of the tongue base would need to be removed. Your endoscopy was very helpful, though, to show that the epiglottis is not involved. It looks fairly exophytic on the endoscopy, which is very favorable. Um, Dr. Thorstad, we lost your PowerPoint.
Okay.
What are your thoughts about this sagittal view of the CT scan? I know we talk about margins a lot in head and neck cancer, but this is, HPV positive disease. What are your thoughts about a close margin there on the tongue base? Because if this patient goes to surgery, and this is a surgery conference, right? So I imagine most of these patients we're talking about operating. At what sense here, that's what, maybe 2 millimeters to the hyoid bone. Does that make you nervous from a surgery standpoint as far as margins go?
Yeah, I think so. Although the exam was it was kind of pedunculated, but I guess there's a deeper component. So that does make me a little nervous. Although certainly we can treat for a positive margin with pretty good results. But it
What
does
if the
make
margin's negative? What if the surgeon took this patient to the operating room, resected this, and they had a 1.5 millimeter margin there or a 1 millimeter margin?
yeah. I consider that close, and I think that would certainly require treatment. In the ECOG 3311 trial, I believe the surgical margin needed to be 3 millimeters, 2 or 3 millimeters, which would be considered not close and not in the intermediate group.
Gotcha. Great. So Zoe, what was your discussion with the multidisciplinary team on this patient?
So we talked a little bit about kind of treatment options. We reviewed that there were a couple different options. I think one of the big things that we stressed was that the options were essentially equivalent in terms of survival outcomes. We did get him a PET scan just to ensure that there was no distal spread and there was local regional spread as we expected in that left neck, but no distal metastasis. And then we talked a little bit about kind of what he as a patient could expect from each of the outcomes. We talked about kind of short-term versus long-term morbidity, what the surgical approach would entail, and what we were thinking about with that. He was a relatively healthy guy, so I think we had very low concern that we were going to impact his swallow to such an extent that he wasn't going to recover with the surgical resection. But had he had more comorbidities, I think that may have been something that we think about. We talked a little bit about kind of what he could expect from chemoradiation, both kind of from a short and long-term side effect standpoint, and then also from a impact to daily life standpoint, at least for the duration of treatment. I can't remember what his occupation was, but I think he was a little bit hesitant about taking the full 6 to 7 weeks off for definitive radiation and chemoradiation therapy. So that was definitely something that impacted him. And then I think we talked about kind of, because we were the ones in the room, we talked a lot about kind of what the surgery would entail and how we were making our decision.
Yeah. Dr. Thorstad, what are your thoughts if this patient had non-surgical therapy, if that was their choice or the team's recommendation, what would the treatment be from your standpoint for definitive chemoradiation?
Yeah. So he'd need 70 gray radiation therapy to the primary and the positive neck. And because it's base of tongue, his risk of contralateral disease in the neck is at least 20%. So we treat that both sides of the neck. The right side of the neck, though, could go to a subclinical dose of 54 gray.
Mm-hmm.
So, you know, just a point about the taking off time from work, it might actually be shorter with chemoradiation. It's 7 weeks and then some recovery. If you go surgery first, you've got surgery, you've got some recovery, then you start radiation. So it might actually be a little bit longer.
Yeah, I agree with that. So you bring up a good point about the contralateral neck. We've researched this. Other institutions have looked at this too. None of us have great data to say how far away something really needs to be before the risk is so high we need to dissect or radiate the other neck electively. But I think most people do agree that once it reaches the midline, that the risk does approach probably 20% risk of occult nodal metastasis on the other side and warrants elective treatment, either surgically or with radiation treatment. If your surgical team operates on the contralateral neck and it's pathologically N0, are you still radiating that neck in HPV positive oropharynx cancer?
Oh, well, we aren't at WashU because we did a phase 2 study and looked at that. And if the contralateral neck was clinically N0 and pathologically N0, and then we didn't treat, the failure rate is on the order of 2% at the most. So we feel pretty comfortable. And that decreases the radiation volume about in half. So we think that's kind of trading a selective neck dissection for bilateral radiation and just doing half of that is, we think that's a good thing in terms of quality of life moving forward.
Great. Why don't we go to the next slide, Zoe, and then I'm going to pick on some of the other panelists too.
Sure. So this is just a quick snap from intraoperative. He underwent surgical resection with bilateral neck dissection and ligation of arteries on that left side. His pathology showed a 3.4 centimeter base of tongue lesion, HPV positive, P16 positive SCC. There was no LVI or PNI, and his margins were negative. In the left neck, he had 2 out of 20 lymph nodes. The largest was that palpable deposit at 3.2 centimeters, and there was no evidence of extranodal extension. And in the right neck, he had no positive nodes out of the 24 that we got out of the neck dissection.
Great. Yeah, there's a lot to dissect here and to consider when considering your adjuvant treatment and what the next steps are. You know, margins are negative. I'm sure the one by the hyoid bone was fairly close. I'm very, very comfortable with that. If clinically in the operating room, things looked clean at that area. Sometimes you're chasing margins, and even though you get a negative margin, those make me more nervous than a patient like this where it's close, but you can tell you're just around it on imaging, you're around it on your surgical resection bed, and it just looks good. It's the patients where you're chasing margins is where I really get nervous about our confidence that the negative margin's truly negative. I guess the other risk factor is, you know, having 2 lymph nodes. Another risk factor is the size of the lymph node. I personally don't think that's much of a risk factor. It hasn't really shown to be in the HPV positive population. Who's on? Is Linda on?
Yep.
So I don't know how you guys are managing the contralateral neck now. I know when I was a fellow at Mayo Clinic, they were radiating the opposite neck. How would you guys have managed this patient's neck disease?
We are electively dissecting the contralateral neck. It really, I mean, I think at all institutions there has to be a really close conversation between the surgeon and the radiation oncologist. Of course, it's I I think it's super important, as you just asked Dr. Thorstad, to clarify if the radiation oncologist is comfortable omitting radiation to the contralateral neck if it's a PN0 neck with appropriate lymph node yield. We do believe in lymph node yield, and you guys have published on that. And I think that if the answer is that the radiation oncologist is not comfortable emitting elective radiation to the contralateral neck, then I would actually hesitate to dissect the contralateral neck, because we know that the morbidity of neck dissection plus radiation is greater than radiation alone or neck dissection alone. So I think there has to be a very close conversation there. But in a situation like this, we would certainly, there's no question there's at least 20% occult nodal disease risk in a case like this where it very clearly crosses the midline. I personally would talk to the radiation oncologist if they're comfortable omitting radiation. I would do the contralateral neck. The bigger concern, though, in a case like this, and we haven't talked about yet, is the bleeding risk in these larger tumors that cross the midline. And I don't know if we're going to talk about that later on, but we do prophylactically ligate vessels, and we can talk about if everybody believes in that or not. But it gets challenging in these really big tumors, right, where we're going to go pretty deep on the contralateral base of tongue too. And that sometimes influences our tumor board discussions on whether to take somebody to surgery.
No, absolutely. I think having a multidisciplinary discussion is exceedingly important. And, I'm pretty blessed to work with the radiation oncologists I work with, but we also work with community radiation oncologists who are not quite so facile. They're very dogmatic, and everybody kind of gets the same thing. So, even some of those patients I won't even operate on, let alone do the other neck, because I know they're still going to get 66 gray to the primary site, whether I get negative margins or not. So I agree with you 100%. Understanding what your team is going to prescribe is very, very important, because if they're going to radiate the other neck, this patient doesn't need an elective radiation and elective surgery. They just need one. So that's an excellent point. Karthik, do you guys worry about this patient's smoking history? I know a lot of people talk about that, and some people get nervous about smoking history and want to intensify their treatment, and others do not. What are your thoughts about that?
Yeah, it's a good question. I used when the Ang paper came out, like way
Mm-hmm.
back when, everyone was wondering about this 10-pack year smoking history. Honestly, it's become far less of I don't really even ask. I see it in the intake form because unless there's something weird, like if patients present with pain in the pharynx, which tells me there's something going on beyond what I'm seeing in the scan, then I start to worry a little bit. But if it's, the garden variety presentation, which is a painless neck mass, they're asymptomatic from or near asymptomatic from a swallowing standpoint. I don't really pay much attention to the smoking history.
I agree with you. They may do worse overall in life, which makes sense, but I don't think our treatments are impacted by the fact that they smoke or not. I think I agree with you that we document it and then we kind of
Right.
move on. We don't make treatment decisions based on that, but I know some people do, and I'm always curious to hear their thoughts. For sake of time, though, Wade, what would you recommend for adjuvant treatment now? This patient has a T2 tumor, clear margins. Can we go back?
Oh, yeah.
Oh, is this it? Sorry, yeah. 2 lymph nodes. I think that's important to consider. One was 3.2 centimeters. Again, I don't put too much weight into that. But no E&E. The contralateral neck was clean. What do you think you would recommend?
Yeah. So if it was one lymph node, it used to be 3 centimeters was an indication for irradiation. But I agree with HPV positive, no ECE. We've gone up to 4-ish centimeters. I get a little nervous above that, but we've done it. But 2 lymph nodes puts them into an intermediate risk. That was the intermediate risk on the ECOG trial, and on a lot of previous RTOG trials, so I still think that that's important. So I'd recommend post-op radiation therapy to the primary site and the left neck and not to the right neck.
I think as the surgeon on the case, I would agree 100%. And if they qualify for the ECOG dosing, we've been practicing that way now since the trials come out with what I think is pretty good success anecdotally here. We don't have long-term follow-up institutionally on those patients, but we do have long-term follow-up through the trial itself that we enrolled patients on. So this patient would probably get 50 gray based on the ECOG trial. Zoe, how did the patient do post-operatively, and what did you guys ultimately recommend?
He did very well. He was admitted for 2 days, discharged on a soft diet, and functionally was doing very well at 2 weeks, had minimal swallow deficits, nothing that he could appreciate in terms of aspiration or anything like that. His pain had generally subsided and his incisions were healing well. He actually took part in a trial, so I think probably otherwise would have gotten what Dr. Thorstad had mentioned, but because we have an ongoing trial, was enrolled in that.
Yeah, so he got even less than, which makes sense, but off trial, he probably would have been prescribed the ECOG criteria of dosing. So, some anatomic considerations on this. We'll spend one more minute just because we started a few minutes late, and we'll give everybody their 20 minutes. But, I think some important anatomic considerations are the anterior extent, how far it goes to the highway bone or in front of the highway bone. Because think about your angle of approach with a robot. I don't have the ability to make a laser pointer, but imagine a robot arm coming into the mouth and then making a 90-degree turn. It's just not going to do that. So if these tumors are going really far forward to the highway bone, you're going to have a hard time getting the tumor out, exposing it. Plus, the muscle you're cutting out becomes more and more important for speech and swallowing. And I think the second anatomic consideration, and the sagittal shows it well, is that epiglottis involved at all? And in this case, the endoscopy showed it was not involved. That's very important for our radiation oncologists when they're planning. And that's also very important for us because if we have to remove the epiglottis also, that patient's going to be affected pretty severely from a swallowing standpoint. If they lose a large portion of their tongue base plus their epiglottis, they're going to have a really hard time. So those are some things you want to consider anatomically, both from an imaging standpoint, but also from an examination by palpating and your endoscopy.
And one real basic point, I kind of rib my residents if they do their exam, but they don't have the patient stick out their tongue. Any tongue that deviates probably is not a surgical candidate.
Yeah, if it's deep enough to impact muscle, even if it's not paralyzing a nerve, sometimes you'll see tongue deviation from tethering secondary to the tumor involving the intrinsic and extrinsic tongue muscles largely. And yeah, I agree. That patient's going to lose a lot of valuable tongue muscle, which is going to have a bad outcome that they would otherwise probably have a better outcome with definitive chemoradiation therapy. Great job, Zoe. If we don't have any other questions about this one, I'm happy to answer. I don't see anything in the chat. Why don't we move on to Karthik's team? And we'll save Dr. Yin for last.
All right, sounds good.
This is Dante Merlino. Really appreciate it.
Of course. Can you hear me okay?
Yep, and we can see your slides.
Perfect. So yes, I'm Dante. I'm here over at Penn with Dr. Rajasekaran. And today we'll be talking about management of an oropharyngeal unknown primary tumor. So this is actually kind of an interesting case. We picked one from a while ago just because we have some long-term follow-up on the patient. This gentleman initially presented back in 2018 and was 81 years old at that time, former smoker, not a extensive smoking history, but over that 10-year 5-year history that Dr. Raj did mention. And he essentially had an incidentally discovered neck node that was discovered when he presented to to the emergency department for stroke-like symptoms. So he got a CTA to essentially evaluate his carotid system and his stat CT head. And they saw a pathologic node in the ED at that time. He had an otherwise unremarkable head and neck exam. The ENT service was consulted and scoped him in the emergency department. Didn't see anything, couldn't palpate any nodes, but he was ultimately referred to ENT for follow-up, given the pathologic node that was identified. And this is just a CT scan that was obtained in the days following that CTA. And then just to, briefly kind of talk about the workup for this gentleman, that initial emergency department visit was on the 29th of November. We got him in to see Dr. Raj on the 5th. And again, at that repeat exam, scope was repeated and, tongue-based, tonsils were palpated. Everything was essentially unremarkable. That CT neck was performed, which I showed previously. And then an in-office ultrasound-guided FNA of the right level 2 lymph node was performed on the 10th of December. That demonstrated squamous cell carcinoma. I think because it was an FNA, there was not sufficient tissue to perform P16 testing on that. A PET CT was performed on the 19th, so about like a week later. And it showed this, a hypermetabolic lymph node, but no real FDG avidity in any of the potential primary sites, nasopharynx or pharynx. And so then he was taken on the 27th.
Hang on one second, Dante. Sorry about that. So I guess this is a good time to talk about if I were to pull, Dr. Sumer's not on, but looking at this. Would anyone order any other diagnostic imaging for this patient? I mean, would people order an MRI?
I would not. I'll let Linda answer as well, but I would not. I don't find it that valuable. I know some people love MRIs. I'm in the opposite camp. I don't understand them or know how to interpret them, to be honest with you. I examine the hell out of these patients. I smash on their tonsils and smash on their lingual tonsil, and then I do an endoscopy, and I'll pick up a few in the office that way. I see very few unknown primaries now going into the operating room just by being a little rough with my exam, honestly, trying to stir something up and target something. But you're right, you don't find all of them. But if it's that small, I don't know what the resolution of MRI is to find a sub-centimeter occult primary, in tonsil tissue. Linda, what are your thoughts?
Yeah, we also don't use a lot of MRI. MRI, so specifically for this unknown primary scenario, I've not, I don't know the literature on it very well, and I've never used it for that indication. But in general, for the existing tumors that we can see, the MRIs tend to upstage, and particularly for the base of tongue ones, it can get a bit confusing.
Yeah.
And I worry about it upstaging, but so no, I wouldn't. I agree with Ryan at doing a really good exam and being pretty rough. Sometimes you see just a little bit of friability that clues you in. And I do think as we'll probably get to talk to, the TORS workup for this is not all that morbid. It shouldn't be all that morbid to do a TORS workup for this. So
yeah. Now, I would also make another comment. I think a lot of people talk themselves out of tumors on PET scans. I think the PET scan probably identifies it more often than we give it credit for. I'm not sure why, but I feel like, at tumor boards, at these conferences, people say it's an unknown primary, and then they actually scroll through the PET, and it's like, well, no, it's right there. You can see it. So it'd be interesting to see all the images of the PET scan, because I think oftentimes there is some asymmetry in the GTS or in the tongue base or somewhere. It doesn't even have to be a lot of asymmetry, but something to at least give you a target.
Yeah, it's a good point. So I think the literature says PET scans, it's 40% false negative, but that doesn't mean it's a bad test to order. I mean, you don't hurt yourself by ordering it, and it gives you some information is better than none. And you use it just with the rest of the information that you have. And it can kind of clue you into maybe focusing your initial look in that spot. And if it's not there, you're still going to complete the endoscopy. Um, so perfect. So, I mean, this case was one of my first ones. I think I did the six or early ones about 6, 7 years ago. So we changed our algorithm a little bit, but I think Dante, if you want to talk about what we did,
Yeah.
then.
All right. Ultimately, we took the patient to the operating room for essentially the TORS workup, like Dr. Yin and Dr. Raj had alluded to. So here at Penn, back then it started with a direct laryngoscopy. Pretty much all of these patients go for a DL first here, just to see. Obviously, you get a chance to get a little bit of a better look than an in-office nasopharyngoscopy, and maybe there's something you can pick up that you didn't see during your clinic evaluation. There was nothing that was seen on the DL for this patient, so at that point proceeded to an ipsilateral tonsillectomy. That was examined on the back table, palpated, and essentially, looked to see if there were any small mucosal lesions that maybe were not appreciable in the office or on the DL. And that was essentially unremarkable. So at that point, proceeded to a right tongue base resection. And then again, this was kind of an earlier unknown primary protocol. At that time, there was concern that any sub-centimeter lesion might not be identified on frozen pathology. So actually a minimal left base of tongue reception, essentially limited to the lymphoid tissue, was performed. And then both of those were submitted for permanent pathology. And then at the end of the day on permanent path, a P16 positive squamous cell carcinoma, specifically a 2 mm focus of that, was identified involving the medial margin. Obviously, in this case, the medial margin was right up against the left tongue base resection. And on that, they actually didn't identify any tumor on final path for that.
Yeah, so this is one of those cases where, I mean, I think a couple of things, unless we palpate a tumor grossly, we don't cut into the tumor because some of these tumors are so small, we like to bread loaf them. So that's why, unless we palpate something in the tonsil, we don't do anything. Then now I basically take out the entire lingual tonsil. But we do the right side first, and then the left side just from the retractor placement. And there's a couple of thoughts here. Number one is, let's say you did the right tonsil, right base of tongue, left base of tongue, and left tonsil, and the primary. Well, actually, before that, this picture that Dante's put up, this is not an example of this case, but what we do is we go downstairs and we ink the entire specimen. So that tells us where the medial margin, lateral margin is. And the conversation we have with the pathologist is say, hey, where did you see the tumor? So I know for all my specimens, they take a picture of this. It's in the chart along with the path. So you can tell if it's truly a negative margin or truly resected or not. So here, let's say you did the entire right, you did the right tonsil, left tonsil, right base of tongue, left base of tongue, and you did not find the primary. Wade, do you guys, what would you do then if, forget the neck dissection part yet, would you consider radiating the primary?
We actually don't.
Right.
We published our results a long time ago, a small trial, and there's been a number of similar small trials looking at both treating versus not treating. Because, if we find the tumor, so we found the tumor, yeah, if you find it, yeah, we treat that area usually. If we don't find it, we don't treat the entire head and neck mucosa. We just treat the neck. But yeah, I guess,
Yeah, it's interesting. Oh, sorry, go ahead.
No, go ahead.
I was just going to say, for us, it's whether if we find it and we resect it, we don't treat it. If we don't find it, we still don't treat it. We just published our data on this, and and the thought process, at least we have, is perhaps the tumor is smaller than a millimeter, maybe, and it was missed in the slicing. But
I want to ask Dr. Yin real quick. What is your approach? Because we published on unknown primary before TORS was even around in the workup, and Bruce Hoey wrote two really nice articles on how to manage these, and it was pretty groundbreaking in the day. And then a bunch of people wrote another paper with a robot with the exact same thing. But what is your approach to this? Because I know how we've managed it for a long, long time. I'm just curious what others are doing, just to give some differences between UPenn.
Yeah, and I don't know maybe how it was managed back when you were here, Ryan, but we are mucosally sparing, whether or not we find it. Some of that is based on the Penn data that was published recently. And then there's the two find trial, right? That kind of.
My question is, what is your surgical search?
Surgical search. So only the ipsilateral tonsillectomy invasive tongue. Yeah,
Yep.
we don't take out the contralateral invasive tongue. And I
Nor
think
do I.
Karthik alluded this was several years ago, so I don't know, maybe that is the practice the same now, or?
Yeah, we're talking about avoiding questioning about whether we need to do the contralateral tonsil, but the entire base of tongue we do, because you could have a contralateral base of tongue, although it's rare, it's still a possibility. And our radiation oncologists feel better knowing that the base of tongue. Right now, we do the entire both tonsils, base of tongue, but we're talking about avoiding the contralateral tonsil.
I think there's some risk to that needs to be cautioned to the fellows on the call. Taking out entire Waldeyer's ring, I think, is not without morbidity, especially if that patient ends up getting radiation treatment.
But if you spare, and that's why, like the contralateral GTS, you have to preserve. Otherwise, you can
I'd
get
love to see your
circumferential
data
scar.
and see how many you found in the contralateral tonsil that had a single node metastasis to the opposite neck. I would warrant it's probably close to zero and not worth the risk.
That data too.
Yeah, we just published a couple
articles
articles about omitting the other tonsil in all patients, and it's very, very safe.
Yeah.
And then the contralateral base of tongue, I agree. A patient with a unilateral nodal metastasis really should have a primary touching the midline or ipsilateral to that node. It would be very, very rare, I think, for that patient to have a true contralateral lingual tonsil tumor that does not have an ipsilateral nodal metastasis.
The only ones, in my mind, to do that contralateral base of tongue workup, or to take out both base of tongues rather, is if they have bilateral nodal disease, right? But those people
Agreed.
Probably shouldn't really be getting surgery. That's not somebody who's a good de-escalation candidate on or off trial. So we don't do that. I think I don't remember the numbers people have published on this. Maybe you published on it, Ryan, that it's very unlikely to find it in the contralateral base of tongue. And then the tonsil,
close
there's
to
even more literature on. I've published on it. There is a Penn series, is Ohio State. Zach, our fellows from Ohio State, and they feel strongly about taking out the contralateral tonsil.
Yeah, they had 30 patients in their study, and 3 had a contralateral tonsil cancer. We had hundreds and hundreds, and 3 had a tonsil cancer on the other side. So that's just some food for thought. If you did a meta-analysis on it, there would be very, 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 very few patients with contralateral tonsil cancers that are clinically meaningful. I don't want to spend the rest of the day on that, but I think it's important to know that things are done a little differently at different places, and it's probably safe to omit the contralateral tonsil and lingual tonsil. I want to make one more comment about something that Dante said earlier, was that he was taken to the operating room for DL to get a better look. I'm in the camp, and I may be alone on this. I think I get a better look in the office with a distal chip camera and the patient's awake and sitting upright and can move their tongue around and participate in the exam. I feel like I see so much more when the patient's sitting in front of me than I do in the operating room with a metal laryngoscope in their throat and everything's collapsed. Anesthesia already bloodied up everything, and you're trying to see what's going on. Just food for thought, not an argument by any means, but I just feel like I have a way better look in the office. So interesting. You mentioned frozen section. We do send these patients for frozen section because they do find it oftentimes in frozen. It's actually not that common for them to find it on permanent when they don't find it on frozen. So we do their necks concurrently and take care of everything in one operative setting. It's not right or wrong. I know there's really two camps for that. And I know a lot of institutions are still sending these for permanent, waking the patient up and coming back if needed. What are you guys doing today?
Yeah, unless you feel it frozen, wake them up. Permanent, wake them up. You're right. There are two camps. I used to do everything all in one day, and then it took longer, and the cumulative time was shorter bringing the robot in and out, and waiting for frozen. So now I break it up into two days: the
That's
diagnosis
fair.
day and the treatment day. There's nothing. Both were fine for me. I found I didn't have to put Foley's in everyone while I was waiting. So that was my. I had one patient with a UTI, and that was enough. And I was like, I'm not doing this again.
Love it.
But yes, you're right. For convenience sake, it's probably good to get it all done. But
Yeah,
we
we
don't.
just send it for frozen and then start the neck. And then they're calling us
Nice.
about halfway through the neck dissection whether or not they found it. And then we just
Yeah.
kind of move along. And most of the time they find it in the first chunk we send. And, occasionally you're right. You end up twiddling your thumbs for a half hour while you're waiting for frozen. It's not all of us have Mayo Clinic's pathology, Linda, where you get the pathology back in 12 minutes. But
No, it takes a while here too, but I agree. There's no reason why you can't start the neck in these cases, right? Like it is. I can remember. I think we can all remember cases where maybe you end up with a positive margin and an unknown primary. You have to go back, and that's always embarrassing for us. But it's pretty unlikely. Usually they're really really small.
mhm.
And so there's not really anything else left to do robotically. It's nice to know, but I think that it goes back to having the conversation with the radiation oncologist, right? It's important for me. It's important knowing that the patient's going to be spared mucosally no matter what, whether or not we find it, and so it lets
Yep.
me comfortably move on to the rest of the operation, and
Yep.
it's not going to change their outcome.
Yep. So Dante, I agree with you, Linda. But yeah, Dante, you guys found a 2 mm primary. I assume you did a neck dissection, maybe even bilateral neck dissections, depending on institutional practices. Yeah, here it looks like you did bilateral. Tell us a little bit about that, and maybe we'll ping Dr. Thorstad to see what he thinks. And I'll tell you what I think he'll say, and then I'll see what he actually says.
Yeah, it's funny that we already talked a little bit about the bilateral neck dissections, because when Dr. Raj and I were talking about this specific case before this evening, we were discussing about how the bilateral neck dissection might be a little controversial, and make sure we explain that in this specific case, it again is a really important protocol to have a conversation with the radiation oncologist. And
I think that's the most important part right there.
Right, exactly. And so that conversation essentially went in such a way that if, at that time, if we were able to demonstrate the elective neck showing, no positive nodes on the contralateral side, then we'd be able to spare that patient radiation to to the contralateral neck. He ultimately did get that the radiation to the right neck. Just briefly, want to touch on that quickly, and then yeah, I'd be curious to hear what the panelists have to say. But went on to get 60 centigrade to the right neck. No chemo though, and was a mucosal sparing protocol. And then 6 years later, he's doing really well.
That's great. Yep, bread is tough. It's dry. That's something we hear on everybody. I think Dr. Thorstad would say very similar. Then patient probably would have got 60 gray. I think today they'd probably get 50 gray on ECOG, or they would hopefully sign up for our trial and get 30 or 40 gray. I think we would spare the primary at 2 millimeters in negative margins. At least that's what I would be supportive of, because I think it's probably going to get enough from the neck radiation anyway to where it's probably safe. Wade, what are your thoughts on this patient? Very similar to the prior patient, honestly. 2 nodes, one that's just over 3 centimeters. No real bad risk factors. No E&E, nothing crazy. What are your thoughts?
No, I agree. I think that you don't, 2 millimeter tumor that's resected, I don't think you need to treat the mucosa. Some of these are a little bit bigger, and you can let the primary site guide you, but we just treat the ipsilateral neck alone. And yeah, 50 gray or hopefully 42 or so in our trial would be fine, just the neck. Ipsilateral.
Yeah, we're going a little bit over just because we started a handful of minutes late. So I want to be respectful of everybody's time, including our panelists. But does anybody have any questions? The unknown primary is always a fun topic. One, because the patients do so well, so there's a lot of ways to do it and do it right. The patients just do really, really well. They usually have 1 or 2 nodes. Most of them just have a single node. So they're very favorable for surgery. And for all our fellows that are graduating next year and going out to practice, if you're going to a new place, these are great patients to start with, because you build confidence in yourself and you build confidence in your team when you get negative margins and you have good swallowing outcomes in your patients. So your radiation oncologists start trusting you more. You don't want to jump in with somebody with a deep GTS tumor that you're going to have poor swallowing outcomes, even if the patient recovers completely. That kind of sours people if that's their first impression. So these are great tumors to start out with next year.
The one downside is that a lot of radiation oncologists want to treat the entire mucosa, bilateral necks, and that's just, I think that's too much volume. It sounds like this panel is kind of on the same page, but smaller community and smaller places we're trained that way and still want to treat everything, which is, I think, way too toxic for this group of patients.
And we see that too, even being here at a large institution. We take care of patients from 3 hours away, 4 hours away, who just can't physically or financially come to our institution for their radiation, but they can come here for 2 days to get their surgery. I have to know who's treating them, because that's a great point. If they're going to treat all of this tissue anyway to high doses, I don't even recommend surgery anymore. I just say, go get your radiation, you're better off. So, you don't just have to treat the patient, you have to treat the team also. You have to know who you're working with. But great case, Dante, really appreciate it. Always an exciting topic is the unknown primary for sure. We spend hours on this during courses and stuff already, just on this one topic.
Thank you.
Any questions? Again, I don't see any comments in the chat, so I assume the fellows all do it my way, the right way, and we can move on. I think Dr. Yin and her fellow have another interesting case that's a little more controversial, so it'd be fun to talk about and get Karthik's opinion, and especially Dr. Thorstad's opinion from a radiation standpoint.
All right. We are talking about a right tonsil tumor that had a retropharyngeal lymph node. Just a case from last month. This is a 48-year-old male who has former smokeless tobacco. He quit about 10 years ago, but he is a current drinker with 10 drinks a week. In June, he presented to his primary care physician with a 1-month history of a right neck mass, right-sided otalgia, and dysphagia to pills. His primary care physician ordered a CT scan, which you can see here, shows a right tonsil mass as well as a cystic level 2 lymph node. So she referred him to ENT, who performed a DL biopsy of that right tonsil, which showed a P16 positive squame, and then got a PET scan, which is
Can you
seen.
go back to the contrasted scan one more time? It went kind of quick, just so everybody has an opportunity. Maybe go through it a couple times, just so everybody has an opportunity to see what that tonsil looks like.
Pretty large
And then,
tonsil.
yeah, and then go back up and check the border between the pterygoid, because I think that's important when you're considering tonsil cancers. Is it mobile to that pterygoid musculature? And this one looks like it is.
Mhm.
So great.
And what exam maneuver are you, or what questions are you asking the patient, Zach, to understand if there's pterygoid involvement? What's a good clinical sign?
Ask him how if they're having any trismus, if they can open their mouth pretty widely. We routinely push on it pretty hard, not
Mhm.
mash on it like Dr. Jackson might, but try to see if the tonsil's mobile.
Don't lie to me. You know you do. You know you do.
Very aggressive.
Love
Um,
it.
they also got a PET scan shown here, which just showed again right tonsil, and then that right neck mass lights up as well. So they were referred to us for treatment options and treatment discussion. We saw them in August and discussed them in a multidisciplinary clinic, staged them as a T2N1. Their NavDX at that time was 32. We got an updated CT scan, which shows a ipsilateral lymph node, or an ipsilateral retropharyngeal lymph node, which can be seen here on this scan. So with that in mind, we talked to him about different treatment options with this new finding, which was either definitive chemoradiation therapy or TORS, resection of the tonsil, and trying to resect this lymph node with an adjuvant CRT, possibly de-escalating them on our trial right now, which is guided by ctDNA.
So
Retrofit.
in the interest of time, to focus the discussion, I guess we can start with the workup. So are you guys, Ryan and Karthik, are you guys looking routinely for retropharyngeal nodes and scrutinizing the RP nodal basin on images?
Yeah. On every
Are-
patient, I'm looking at it. I would say I have never seen one on a tongue-based cancer, and I think Eric Moore's paper highlights that, where he dissected every retropharyngeal node on, 70-ish patients or something. I forget the exact number, but a lot. He did an open dissection on them. And the tongue bases just don't go to the retropharynx. So it's really your palate, your tonsil, maybe your glossotonsillar sulcus. That lateral pharyngeal wall is what's causing this. But yeah, I check it out on every single patient.
Yeah, I'm the same way.
And in a case where you have a retropharyngeal node that's a little bit plump, we can go back to the PET. So the little bit tricky thing is, right, the avidity kind of overlaps these larger
Yep.
tonsil tumors, and
But
it
if
can
you
be hard to
stop
pick
it
up.
and scroll back and just pause it, you can see it go up there.
Yeah, agreed.
Yeah, I
So,
agree. With PET, it can be challenging if the avidity shines from one spot to the next, for sure.
and then if there's any concern for an RP node, so maybe I'll let Zach talk about his reading. So what is the prognostic concern there with RP node involvement?
It's any RP node seen radiographically has worse disease-free survival, overall survival, distant mets, local regional control. Basically, they do worse in everything.
And this is now very controversial, but would you guys operate on a patient where there was a concern for an RP node?
Is it just one? I guess I would, depending on the number of nodes. If it
Yeah,
was
so
just like
otherwise
one,
the nodal disease here is just otherwise a single cystic node, no obvious radiographic E&E.
then yes.
Yeah,
I
I think
do.
I have a couple. Ask your question one more time. I was responding to Tony. He was leaving the meeting.
Would you operate on any patient who's otherwise would be a good surgical candidate, but there's a concern for an RP node?
Yes and no. I don't think it's that simple. I think the patient their overall health matters to me on these. I feel like their swallowing recovery is slower. I've taken out a handful. Nobody's taken out a ton of these transorally. They're just not that common. But I've taken out a handful for sure, and they do recover, but they don't recover quite as fast. I think it's just a standard radical tonsil when you're dissecting that. I don't know if they're getting more numbness back there and asensate tissue temporarily, but they tend to take a little bit longer to recover. Another thing is the carotid artery you're showing right there is of very most importance to me anatomically. I study that extensively. And if I was a junior faculty, brand new faculty, I wouldn't touch it with a 10-foot pole. I think you need to have some experience in these because any skip moves on an SP robot where you collide and have that collision and it skips, you could cause a devastating carotid injury in this location. Even just heat transmission can cause a pseudoaneurysm here, even if you don't see the carotid or touch the carotid, because the carotid should be in a different fascial plane, right? It should be separate, but it doesn't mean you're not transferring heat to that carotid and causing a pseudoaneurysm. And I've had a pseudoaneurysm on a salvage case. Patient had a flap even and ruptured and passed away, unfortunately, from a pseudoaneurysm, not even from a retropharyngeal node dissection, just from causing trauma to that area that had already been radiated. So I think the carotid is probably the most important thing and what it looks like. I think these do have a risk of E&E. So that's something to be really mindful of, that it might not just peel off like a regular papillary thyroid carcinoma lymph node that you see in the retropharynx that just kind of pops out when you incise it. Hopefully that answers the question.
Then Ryan, if the patient's otherwise resectable, I'm well, and you don't try to resect the retropharyngeal node, I'm very comfortable giving that the equivalent of 70 gray while we're giving the rest of the head and neck much less. And I think that that's controllable with not too much risk.
How about Dr. Thorstad? Maybe not a great, this isn't a specific example of this, but let's talk about like elective radiation to the RP nodal basin. When are you doing that?
We are doing that for on the ipsilateral side for the tonsil. Yeah, we always cover up to the skull base on the ipsilateral side. And we've got, go ahead.
All tonsils or any size or criteria or?
I mean, again, these 2 millimeter tonsils, no, but anything above that, a T2 tonsil, yeah, we do. Just the ipsilateral side, though. We don't usually treat the contralateral side as long as the primary tumor is more than a centimeter from midline, which is hard to tell on imaging a lot of times. It kind of folds over. So with a good physical exam, if it's more than a centimeter from midline, we just treat the ipsilateral side, including the retropharyngeals.
Yeah, and our time is officially up, but like I said, we started late. I would like to continue on for another 5 to 10 minutes if the group is okay. Just because, like I said, we started about 5 minutes late because of technical stuff. So, Linda, I'd like to keep going if you guys are still good. Zach?
Yeah, it's fine with me.
Perfect. So what did you guys do? You talked about treatment options, definitive chemoradiation and surgery and I guess pathology-directed adjuvant treatment. It looks like they're in the operating room here. I see a tonsillectomy defect.
Yeah, this patient wanted surgery, so we did a tonsillectomy followed by a TORS retropharyngeal lymph node excision and then a right neck dissection. This is not this patient, but it's a very similar how we performed the retropharyngeal lymph node dissection with the robot.
I'm going to pause you right there.
Yeah.
Go back to your video because I think you just showed the most important part of this video to me. See that gloved finger inside the mouth? Dr. Yin is palpating some very important stuff there. Why don't you go over that part, Linda?
Yeah, so as Ryan is saying, the most important part of this is the carotid artery. We're going to show the dissection here, but essentially, I think of this RP nodal dissection operation as the person sitting at the head is sometimes more important than the person sitting at the console. So this is not, if you attempt an RP nodal dissection, you don't want a junior resident sitting at the head with the suctions assisting you. So you want to start by identifying and try to understand the carotid artery. And so you can palpate, you can even use endoscopic Doppler to try to understand the location of the carotid. And it's a lot of blunt dissection. So the cautery on the SP is being used to divide some of the fascia to get into the right space. But and as Ryan said, when you get in there, you'll see there's different fascial planes. You enter the fascia of the retropharyngeal space where the RP nodes are, but there's still visceral fascia that's more lateral that's on the carotid, and you don't even really want to enter that space. You want to kind of stay medially within the fascia right on top of the longus colli. And it's a lot of blunt dissection with only minimal use of the cautery to help divide some of the fascial bands. You're using your suction a lot at the head to try to essentially bluntly dissect the fascia away so the node pops out at you. You don't want to really pick up the node very tightly using your grasper, whether it's a Maryland you're using or the other the big graspers on the SP, because you don't want the node to bleed on you. You don't want anything to get blood stained. Ideally, it's as avascular of a dissection as possible if you're in the right planes.
Yeah, it's mostly just pushing it. But if you could do me a favor, Zach, and go back to your CAT scan, I want to show. So that's very important. So I don't know if you guys have your images up in the operating room, but we do, and it's very, very important. Yeah, if I was doing this case, the second the tonsil was out and I was going to start the node, I'd walk over and look at these images and restudy where the styloid tip is compared to the carotid, compared to the node. Almost always, but not always, the carotid's going to be lateral to the styloid process tip. And that's the only spot in our world in head and neck surgery where we have a fiducial marker like our rhinologists and our otologists. They have bony landmarks that are there on everybody. We don't. Our jaw moves. Everything moves that we care about. The hyoid bone's mobile. So we can't use those as fixed points. But this styloid tip we can use as an actual fixed point. Palpate it with your finger before you start making any of these cuts. And if you can feel it and you know the node is medial, you know the carotid's lateral, you can be a lot more confident that you're going to be safe in that situation. So my fellows and I were talking about this just this week about a different patient. I think that's of critical importance to understand where that carotid is. A Doppler is an excellent example if it's a patient that maybe everything's on one side of the bone and you can't use that as a landmark anymore. Awesome idea and something for you guys to think about. Sorry to bogart that, but very
No,
important
that's
points.
really good. Yeah, it's a good point on the styloid. Agreed.
Let's see your dissection.
You'll see a Doppler appearance here shortly too.
Cool. Is that black tool?
Yeah, exactly.
So there's a lot of using the cautery there as a dissector. There's very little turning on of the cautery.
And I would also add, if you have a challenging one, the third arm may or may not be helpful here. It does take up space, but if you have an assistant that can't assist with these suctions very well, it might be very helpful to use it to retract the constrictor medially. I use them on patients where I'm not taking the tonsil out first, like a papillary thyroid carcinoma or something that went to the retropharyngeal node. Those are a little different because everything wants to herniate back in. But this is a beautiful dissection, and that's exactly what they look like. I love it. So why don't you show them the anatomy, Zach? Yeah, exactly.
That you see, and that's really your friend. That's what you want to see. Can you
point that out with your arrow, Zach?
Yes.
And one good thing to talk about, where do you guys put the camera on these and the instruments? Do you put the camera
at the tongue blade, so in the top position?
Yeah, Karthik?
Yep, same.
Same,
yeah.
Great.
And I don't know how you guys usually do tonsils, but for tonsils, often I put the camera away from the tongue blade, I guess is the best, the position that's towards the uvula But for the RP nodal dissection, it's really important that the camera's towards the tongue blade.
All right. So show them where the node is in relationship to the kind of prevertebral plane there. So she's dissecting on the node right there. Yeah, that's beautiful. So it doesn't look like it has gross E&E. I assume that's what your thoughts were while you were dissecting this. What if you got in here and it was just stuck? Would you continue to dissect it and just be real careful around the carotid, or would you stop at that point?
You know, I'm pretty early in my practice. As you said, that gives me pretty bad palpitations. It gives me pretty bad palpitations to do one of these in the first place, and it's got to be one I feel really good about. And if it's not jumping out with the suction dissection, that definitely makes me nervous. As Dr. Thorsat pointed out, you know, we have the option of radiation. People do really well with radiation to this area. That we've had some folks have isolated RP nodal recurrence as well, and it's and they can get isolated radiation to this area. They do very, very well, and it's important to know that that is an option.
Yeah,
Yeah,
there's
go ahead.
surgeons that are too scared to do this operation, and radiation's a great option. But you know, if you can get it out, you know, potentially we can lower the dose and not boost that area. So
yeah, and I would argue there should be surgeons that are too scared to do this. I don't think this is a treatment for everybody. You have to be very careful, and the way her instruments are moving right now are perfect. You're seeing the wrists move, not the elbows. You're not seeing a whole lot of collisions. You're not seeing any skips. You're seeing little pulses of burn on tension, and then bluntly pushing, and then burning minor tension points, and then pushing. That's excellent dissection that's going to keep you safe and keep you from poking a hole into the parapharynx, retropharynx, and into the carotid.
The main critique I have of this is I think the tension could be even better with the suctions. That it's so important to have good tension.
Right. That's where a third arm can be helpful if you have a random intern number 4 helping you out with your dissection. We had a medical student this week that was probably the best assistant we've had in a long, long time, which was actually quite nice. But you're right. A suction could have been placed on that constrictor muscle just to pull it medially completely. But the instrument movement was excellent. I want all the fellows on the call to really see how those instruments were moving in there. Very, very nice.
For the fellows on, just some stitches through that through the muscle there.
Through the constrictor.
Yeah.
Yep.
For the fellows on the call, I think you gain a lot by sitting at the head, by the way, not just for these cases, but for all cases. If you're in 2 fellow programs and your co-fellow is doing the tours, you should be sitting at the head and assisting.
Linda, that's a great point, and I 100% agree on that one. And to Ryan's question earlier, it's a good question, and it may seem like, well, of course you're going to close it. I think the point of Ryan you're trying to make is that when you have a radical tonsillectomy defect and you have an incision in the retropharynx, there's not a ton of tissue to use to close. Unlike just doing like a virgin posterior pharyngeal wall, because sometimes your posterior cut is going to be in that same vicinity. So your medial cut or your medial tissue is gone with your resection. So you have to get kind of creative with regards to what you need to borrow to help close this layer. And in this person, it's important, right? Because as we talked about, the carotid is very close by. So you want to try to avoid pooling of saliva there.
Yeah, excellent point. I agree. I'd probably try to close. You got a nice little cuff constrictor there you could close. You always have the fascia, unless it's stuck to it and it's got E&E. You're cutting through the fascia to get to the space that the node is in. So I would say at minimum throw a couple figure 8s or tacking sutures through that dissolve, and you're probably in pretty good shape, just to keep a little bit of spit off of the carotid region. These patients usually don't leak either, which is kind of nice. You could do a leak test on them if you wanted to, but this is pretty high. When you examine these patients, this isn't anywhere near the digastric or the submandibular gland where they're more likely to leak from like a glossoplasmolar sulcus tumor. So I wouldn't be too concerned about that aspect of things. Karthik, would your institution have tried to take this out, or would you have just gone straight to chemoradiation? Because that's a completely reasonable option for these patients also.
Yeah, I mean, I guess it depends on the surgeon comfort, but most of us are, comfortable. I mean, there's only a few of us who do a lot of tours, and all of us are very comfortable. It's an interesting case because I originally wanted to present a case where I had a tonsil cancer with an isolated RP node, no lateral neck disease. So, that's an interesting question because, back in the day, we used to think, well, the RP node is involved if like the ipsilateral nodal disease burden is high, right? And then and so that's where it would travel to next because it's rare for us to see that. And so, obviously we had a multidisciplinary discussion because if I wasn't going to do surgery, if our radiation oncologist would have said, well, we're going to still hit that area. And here we felt like if I did surgery and there was no there are no bad features, then we would avoid any adjuvant therapy. So that was like a 2 point something centimeter node. Lateral neck was negative, and she's about 3 years out, NED. So, but that's a very rare circumstance. I mean,
Right.
I don't know how many you've had, but I've
Zero.
only, yeah. So, but in this scenario, just like this, we would remove it. Yeah, with the same using the same principles during surgery, a lot of blunt dissection, um, and trying to close that defect the best
Yeah.
we can.
So I think all the fellows today heard a few common themes in these TORS patients. Really study your scans, really know what you're looking at. Try not to get into a situation you don't have a basic understanding of what's going to happen. I think that's really, really important. And also, I think another common theme was these patients have multiple options. The cure rates are about the same no matter what we do to them. So really, it's about what's going to inflict the least amount of morbidity to that patient individually. And that's something you need to think about, I think, on every patient that you're seeing, whether it's a T1N0 or a T3N2 patient. Really think about what that treatment's going to do to the patient, and try to figure out which one's going to create the same amount of oncologic outcomes with the least amount of functional outcomes.
And one important thing I want to point out to Ryan's point is that, I'm not sure that we would have talked this patient, would have counseled the patient the same way on surgery if he wasn't a candidate for a de-escalation trial. And so it's important to understand what the trial options are available and what the off trial, the standard, I suppose, de-escalation standard of 3311, if that's something that's supported by your radiation partners or not. But Zach can show the next slide, but this patient ultimately ended up with only that one other node in level 2.
Mm-hmm.
And so it's a ctDNA based trial we have, and he was negative on day 1 after surgery. So he gets de-escalated the DART Mayo regimen. And I think we're thinking about the overall morbidity of treatment. It's really important to keep in mind if RP nodes do portend a worse prognosis, and a lot of folks may not feel comfortable de-escalating that on or off trial. It could be an exclusion to some trials.
Yeah, and I'm not sure if it should be. That's a whole nother discussion.
Yeah.
Do they do worse by giving them less treatment is probably the most important question, not black and white. Should we not de-escalate them? But like I said, that's a whole different conversation.
Yeah. We
Great
are over
talks,
time.
guys.
Yeah. I was going to ask Dr. Thorstad's thoughts on de-escalation
Please.
of adjuvant treatment on these folks that have RP nodes with no E&E.
Yeah, I mean, I think that's the benefit of resecting them. I think that would not exclude them from our de-escalation trial. But if off trial, again, if it's not dissected, we could still de-escalate the rest of the head and neck and just boost the retropharyngeal node by itself with a small margin. And I think, like you were saying, if these, every now and then you'll see a solitary recurrence in the retropharyngeal area, and those can be treated with stereotactic radiation pretty effectively.
Great point. Well, we went about 10 minutes over our hour. I know we started a few minutes late, but I think it was a good discussion on, an uncommon problem in the retropharyngeal node, but something you're all going to encounter in your career, and having some ideas and tools on what you can do is important. And then the unknown primary, I think, was really good to spend a couple extra minutes on too. So I want to thank our panelists, especially Dr. Thorstad, our guests from radiation oncology, for joining us. Linda and Karthik, my colleagues, for joining and giving their expert opinions. So always great to hear their thoughts on these things. They have a lot of experience and a lot more knowledge than I do, for sure. So it's great to hear it. And lastly, I want to thank JJ, Tony, and the rest of the crew putting this together with us. And most importantly, all the fellows who spent their Wednesday evening listening to us hammer on about something that we're all passionate about, and hopefully can get you guys passionate about too.
Thanks, Ryan.
Thanks, Wade. Really appreciate it. Appreciate you taking time out. I know you're out of town at Astro. So. JJ, any comments? Anything from your end, or how do you want to wrap it up? I know Tony stepped out.
Yeah, no, I think we can wrap it up for the fellows on. I am actually, as we speak, typing out your October curricular assignments. I'm a little late with that, but you'll have it tonight. And yeah, no, this is a great session. So thank you all.
Fantastic. Thanks, everybody. Really, really appreciate it. And thanks to our presenters.